Good evening, and thank you for coming tonight to listen to an update on management of glaucoma. And it's titled for GPs, but I'm happy that their allied health professionals are here because it's relevant across a broader area of our community. So essentially the goal of today's talk is for you to be able to understand what glaucoma is, the goals of management of glaucoma, and the importance of being aware of how important your roles as primary carers is to the ongoing care of these patients, and also to be aware of the resources that are available through Glaucoma Australia. Now, how common is this problem? I suppose I can't stress enough that it's probably the leading cause of irreversible blindness in the world, and the prevalence is going up because we've got an increased ageing population, and you can see from the graph there that the overall prevalence of primary open-angle glaucoma is around 2.3%, and it accounts for about 8% of visual impairment amongst Australians, and 16% of blindness are related to glaucoma. Now, there's a lot of figures there, but essentially the health cost of glaucoma is significant in our community. And these are figures from 2005, 342 million, and it's growing at a 5% per annum. So overall, glaucoma accounts for about 75 million cases worldwide. And again, as the age increases, there's an increasing rate of glaucoma, up to 15% in people over 80 years of age. Most significantly, in developed countries, about 50% of people don't know they have glaucoma. So they're going along losing sight, and they're the group that we need to identify in our communities. It's estimated that by 2020 there may be 110 million people with glaucoma. And again, it's the commonest cause of irreversible and preventable blindness worldwide. The World Health Organization figures show that there's about 7 million people bilaterally blind from this disease. So it's a significant problem. Now, why is it such a problem? Well, first of all, it's asymptomatic. Patients don't know they've got it until late in the course, unless specific questions are asked of them. And screening tools are imperfect, but probably the most significant thing is that if family members are of people with glaucoma, if you screen their family members, you're going to have a higher hit rate of identifying those people with the disease. The other problem is that patients progress at different rates. Some people may get the disease and with simple treatments may stay stable all their life. Other people have rapidly progressive disease, and that makes our job harder because we have to monitor them more closely and recognise those people and treat them aggressively, possibly even with surgery earlier. So the aim is to pick up those individuals who are at risk of losing their peripheral vision and central vision during their lifetime to prevent functional blindness, and that's through screening, case opportunistic detection, or those who already have the disease. So as general practitioners, the important thing is to be aware of the risk factors. Who's at risk of developing the disease? Ensure that at-risk patients have comprehensive eye examinations, and you need to be able to relate the eye examination findings within the context of the overall health issues of that individual. So for patients on treatment, you have to see glaucoma medication within the context of all of their medical therapy. And glaucoma is a chronic disease, and you have to look at these patients within the paradigm of chronic disease. It impacts on their lifestyle, impacts on their ability to work, and there's issues of adherence to medical therapy. So as the primary point of care, GPs play a very important role in coordinating input from the specialist providers, and important in reinforcing compliance within these patient group. Who's at risk? We saw earlier from the prevalence data, it's more common as people get older, but it doesn't preclude the younger group. So most importantly, the evidence supports that if we screen that target group, that's at higher risk of developing glaucoma, then you're going to be able to identify the group that we need to identify, and it's not appropriate to screen the general population. So the first-degree relatives of patients with glaucoma, and it's
recommended that if someone has glaucoma, then their first-degree relatives should be screened up to 5 to 10 years earlier than that diagnosis was made, at least to establish a baseline for those family members, and you can monitor change over time. So it is important that patients with glaucoma tell their family members. It's so often I see patients that say, no, there's absolutely no family history, they've got terrible disease, and when they come back for their 6-week visit, having started them on treatment, they've asked, and it's surprising how many come back and say, well, actually, Mum did use drops before she passed away, and no, I wasn't aware of the problem, and my sister and brother. So unless people ask the members of their family, they're not going to be aware of whether there is a family risk factors. Caucasians and Asians over the age of 50, regardless of whether they have a family history or not, should be having eye tests, because that group, there's a risk of them developing glaucoma as they get older anyway. So even if they don't have the family history as a risk factor. And African-derived populations over the age of 40 are at increased risk of glaucoma at an earlier age, and also a more aggressive form of glaucoma. So as we have more immigrants coming from Africa, then it's crucial that we screen that group earlier. So what is glaucoma? A lot of patients think glaucoma is associated with trachoma. So it's important that we have a clear understanding to explain to patients. It's a chronic progressive optic neuropathy. So it's characterised by the optic nerve becoming damaged. It thins out, and that's what I'll describe as structural damage of the optic nerve. And ultimately, after you lose a certain amount of your optic nerve, it leads to functional damage, loss of your peripheral vision. You'll see that the raised intraocular pressure is not part of the definition, but it's an important risk factor for damage in patients with glaucoma. But there's about 30% of people with glaucoma may have a normal pressure. So if you just screen for patients with a high pressure, you'd be missing 30%. This is an example of a classic case of glaucomatous optic neuropathy. So the optic disc typically has the inferior optic nerve, the inferior rim of the optic nerve is the thickest part, followed by the superior, then the nasal part and the temporal side here. So you can see that the inferior, which is meant to be the thickest, has got quite a significant notch there, and there's a matching visual field defect on automated perimetry. So when we see that, that's a classical diagnosis. You don't have to wait to look to see progression in a case like this, because they've got definite glaucoma. So how do we detect cases? Well, first of all, patients at risk should come and have a full comprehensive eye examination. Taking the history is important. Looking for risk factors. Short-sighted people, obviously the family history. Short-sighted individuals may be at higher risk. There's other factors that we look for within the eye, and the most important things are that we check the pressure with tonometric measurement, and although that may be beyond the scope of what you do in general practice, there are now handheld equipment, pieces of equipment that you can use to measure the pressure accurately, and if someone is particularly keen, they have a method of checking the pressure of their patients. And disc cupping, which requires ophthalmic examination. Important to be aware that there are significant false positives for both of these examinations. So we use ancillary testing methods, the automated visual field and the optic nerve imaging, the optical coherence tomography, which maps out the thickness of the nerve fibre layer to support what we're seeing clinically. This is a diagram that I thought I'd include here to help you conceptualise how glaucoma progresses. At this end of the spectrum in the yellow, you'll have a normal individual. They don't have any disease, and as time goes on, what happens is that you get accelerated cell death, ganglion cell death, and that eventually leads to thinning of the nerve fibre. No one may be able to detect the disease at this early stage. Eventually, you start to get cupping, thinning of the nerve fibre layer, as we saw in the slide earlier. And they may still be asymptomatic, and the idea is to pick up the disease while the patient is asymptomatic, before they start to lose function, because as time goes on and they continue to lose nerve substance, you start to get the visual field changes, which may be mild initially, becoming more severe and leading to eventually to blindness. So, as I said earlier, strictly to diagnose glaucoma, you have to see progression or change over time. But obviously, if you've identified a patient with nerve cupping, visual field loss, high pressure, you treat them, you don't wait. But there's that group that falls into the grey zone of that continuum where you may be seeing some suspicious changes, and in that group you may monitor them over a couple of years regularly looking for change over time. So we're following patients with serial disc photos and optic nerve imaging, and obviously pressure measurements and field changes. You might ask, why don't we just, if you're suspicious, why don't we treat everyone? Well, once you start treatment, you're committing that patient to lifelong treatment with drops or whatever treatment approach you take. So it is important that they have disease that will impact on their quality of life. So if I see someone who's 90 and has mild disease, my approach may be very different to someone who's 40 and has more advanced disease. So we have to take that, the input. You don't want to overtreat patients either. There's obviously a group that may have high pressure and normal fields, normal discs, and that group again can be monitored off of treatment until you identify change. This slide just gives you an example of how progressive glaucoma damage can lead to progressive field loss. Now, I'm not sure over what period of time but typically it would be about, you may see changes like this over a 5-year period. The visual field defect is initially at the nasal aspect, and you can see as glaucoma progressed, it came across, and it's probably involving now the central 10 degrees of their visual field. So this patient will be aware of a blind spot in the centre. When they're trying to read, they'll complain bitterly that there's something impairing. It's irreversible, so you want to avoid this situation because you can't recover any of that sight. The second half of the slide just shows that with the automated visual field testing we have, it can give you a graphic representation of the visual function over a time. So it is a great way of showing the patient that they're staying steady. This patient's dropping very rapidly, so I'd be considering fairly urgent surgery when you see it starting to dip like that. So some of the jargon you may come across from letters, either from the optometrist or the ophthalmologist. Ocular hypertension. These are patients that have got a pressure over 21 millimetres of mercury, but they've got normal fields and normal discs. So I'll talk about a study that supports whether we treat those patients or not a little bit later. Glaucoma suspects is that group that falls into that grey zone where they may have a slightly higher pressure, normal pressure. The disc looks a little bit suspicious, but you're not happy to, say that there's significant glaucoma yet, and the field may be a little bit suspicious. If you've ever done a visual field test, you'll realise it's quite demanding, and a lot of the patients that we're treating are over 60, 70, and they're not an 80, and they are not used to electronic gadgets and games. So it's quite a demanding test, and I always find that you've got to give the individuals a chance to learn to do the test better, because there's a certain learning element with visual field tests, and so that's where it's important not to commit someone to glaucoma treatment based on one poorly done test, which may be due to poor reliability. And normal tension glaucoma is where you see the classical cases of glaucomatous cupping. The visual field's abnormal, but the pressure's never been recorded over 21 millimetres of mercury. And as I said, about 30% of people have that form of glaucoma, more common in women between 40 and 60, and more commonly the visual field defect presents smack bang in the middle. So it tends to be a nastier form of glaucoma. Now, how important is pressure in causing glaucoma? This graph just shows that as the pressure increases between 20 and 30, there's almost an exponential rise in the risk of visual field damage. So you might say, well, wouldn't you treat anyone with a pressure over 21? If a patient has a pressure over 30, I treat everyone, regardless of whether they've got a healthy disc or a healthy field, because over 30, patients run the risk of obviously glaucomatous damage, but also there's a risk of a vein occlusion, a more rapid onset visual loss from congestion of the optic nerve. And so in those situations, I explain to the patient that in order to, by lowering the pressure, you reduce their risk profile of going on to develop glaucoma. So is there a benefit to lowering the pressure? Definitely yes. By lowering the pressure, you prevent the development of glaucoma and damage in patients with elevated pressure. But even in patients with glaucoma, there's strong evidence that if you lower the pressure, then you slow disease progression. So it's important to help patients understand the importance of adhering to treatment. So what's the role of the GP in the case detection? I think it's important to understand that primary open-angle glaucoma is asymptomatic. Up to 50% of people within our community may have glaucoma and not know it. Mass screening is not advocated, but targeting that high-risk group, patients over 50 and those with a first-degree relative with a history of glaucoma will allow early detection. And the diagnosis requires a comprehensive eye examination together with the ancillary testing. So pressure alone, as I said, is an imperfect screening tool, and we're looking also for cupping of the optic nerve and visual field changes. So what are the types of glaucoma we see? Broadly, glaucoma is divided into open-angle glaucoma and closed-angle glaucoma. And in both of those groups, they can be a primary cause or there could be secondary causes. And there are a very small number of glaucomas we see with congenital and juvenile onset glaucoma. But the vast majority we see in Australia are the open-angle glaucoma. It accounts for about 80% of disease, and the genetic component in primary open-angle glaucoma is about 18% of cases. You won't be able to tell by looking at the eye because the eye is structurally normal externally, and again the pressure may or may not be elevated because up to a third will have a normal pressure. The secondary groups of open-angle glaucoma, there's some underlying process happening in the eye. The angle is still open, but there's something that's triggering the pressure rise. It may be uveitis or inflammation. It may be pseudoexfoliation, which is a fibrillar protein that's deposited within the eye and it clogs up the trabecular meshwork. More common in Northern Europeans, more common in Southern Europeans, Italian, Greek populations, and it's quite an insidious onset but relentless in causing quite aggressive damage. Pigment dispersion, as the name describes, is the picture here shows the pigment has been rubbed off the iris and you can see transillumination defects, and that's more commonly seen in myopic eyes, young men more commonly between 40 and 50, 55, and the pigment rubs off and blocks up the trabecular meshwork. And here you can see what we call a Kruckenberg spindle, and it's just the pigment that's rubbed off and floating through the fluid of the eye and being deposited. This is in the lower picture here. It's being deposited on the cornea. Lens particle glaucoma, less common. Traumatic glaucoma is a significant one, particularly in our Indigenous. Trauma tends to be one of the more common causes of visual loss and glaucoma that goes associated with that. Steroid-related glaucoma is really important to recognise. Patients that are on oral steroids, patients that are on topical steroids, any steroid creams around the eye, in a population that has the increased vulnerability to develop steroid-related glaucoma. Even a 2 to 3 week course may result in a rapid rise in their pressure. So if you're going to have patients on long-term steroid therapy, I think it is important that they do have an eye check to ensure that they don't develop a pressure rise. And compression of the orbit through thyroid eye disease, retroorbital tumours, again very rare, but represent that secondary group of glaucomas. Sorry.
So with the steroid stuff, would that apply to inhaled steroids?
It's less less commonly seen, but patients that are on high dose of inhalational steroids and have glaucoma, I have to watch them a lot more closely because they do get pressure spikes. The second form of glaucoma is less insidious. You're going to have symptoms, but even with symptoms, a large number of these go unrecognised. You'll have the typical scenario would be a 74-year-old woman, a 2-day history of a painful eye pain radiating to the back of her head. She's been nauseous, vomiting. A lot of these patients present acutely and have brain scans because they're thinking stroke, subarachnoid hemorrhage. But don't forget angle closure glaucoma. Or angle closure crisis. The typical appearance would be the cornea is a little bit cloudy, there's a bit of conjunctival injection, the pupil's mid-dilated, unreactive, and if you actually just touch the eyeball, you'll feel it's rock hard compared to the other side. You don't need any special instruments. So the acute angle closure crisis, the pressure can escalate from 40 to 80 millimetres of mercury, and although strictly by definition they may not have glaucoma damage, if that eye is not picked up, if that pressure is not picked up or the condition isn't recognised, then that eye rapidly loses sight. You may also get angle closure that's less acute, and the patient may present with intermittent headaches, intermittent blurring of vision, halos in their vision when they're driving at night. And it's important to be aware that that could be a intermittent angle closure episode, and so that those patients get assessed. Angle closure can be from a secondary cause, and probably within the population you might see in Darwin, proliferative diabetic retinopathy can lead to proliferation of blood vessels within the front of the eye, the anterior chamber, and that closes up the trabecular meshwork, so you get a angle closure from proliferative diabetic retinopathy, what we call neovascular glaucoma. From the schematic diagram there, you can see that what's happening in angle closure is that the trabecular meshwork, which is where the cornea meets the iris, there's occlusion because the iris plugs the opening. Now, anything that dilates the pupil can precipitate an acute attack in at-risk patients. Anticholinergics, tricyclic antidepressants, and the SSRIs can cause bilateral angle closure because they cause swelling and rotation of the ciliary body and can trigger elevation of pressure fairly acutely. So if a patient has open angle glaucoma, you don't need to be afraid. It's safe to use any of those medications. If they've had a laser iridotomy, a hole that goes from through the iris prophylactically for narrow angles, it's safe to use any of those agents, and you don't need to be afraid to dilate them. And if they've had cataract surgery, then again, those agents are safe to use because you've removed the bulk of the lens, the cataract lens, and by replacing it with an implant, you get the opening up of the angle and no threat of closure. So in general practice, you need to be aware of symptoms of acute and subacute angle closure, periocular pain, headache, blurred vision, halos around light. Considering your differential diagnosis of headache and migraine of patients where it just doesn't seem to be settling. It can be a dramatic attack, but it can be episodic and recurrent. Be aware of the at-risk groups. As I said, the elderly who haven't had cataract surgery, hypermetropes or long-sighted individuals, and it's relatively common in Southeast Asian population, even in middle-aged patients. So in that group, it tends to be more a chronic angle closure. It's one of the more common forms of glaucoma in Southeast Asian populations. So, and that won't be picked up unless it's examined with a special a gonioscope to look at the depth of their angle. Also be aware of the medications that can trigger an acute attack, and maybe refer patients if you're concerned to exclude an occludable angle. So reinforcing, patients with angle closure may present with headache. Suspect if they've got it might be a mildly red eye. It's amazing how much older patients will put up with, and they may not complain of the eye pain, they'll complain of the headache and the vomiting. So suspect it. Developmental glaucomas are rare but nasty. Congenital glaucomas account for about 1 to 2% of all glaucomas. Typically, you'll see a ophthalmic eye, or the high pressure in an eye that hasn't completely developed will result in quite a dramatic expansion. So you can see here in this slide the eye that's got glaucoma. And we see juvenile glaucoma as well in a teenage group, and unless they are picked up through screening of other with a known family history, if teenage children are complaining of rapidly changing vision or prescription changes, it could be representative of glaucoma, so it is important they get checked. In this world of evidence-based medicine, what are the studies that guide our treatment? The ocular hypertension treatment study looked at a large cohort of patients that didn't have glaucoma. They had high pressures, and they treated. There were two arms, one arm that was treated and the other arm that wasn't treated. And of the treated group, 5% went on and developed glaucoma after 5 years. And of the untreated group, 10% went on and developed glaucoma. So what the study identified is that we don't need to treat everyone with high pressure, but there were certain risk factors that identified that if patients had those risk factors, then it would be appropriate to start treatment earlier to prevent their progression to glaucomatous damage. So if we treated everyone, we'd be of 20 patients, only one of them would need to be treated. So it's important that using the risk factors as a guide to treating those patients. One of the things that came out of that study was that the corneal thickness of patients with thinner corneas seem to be more vulnerable to developing glaucoma. So when we're seeing patients and I call it profiling, besides the pressure and the optic nerve assessment, their corneal thickness is an important factor as an ophthalmologist, and optometry also will use that as a guide as to their risk of developing glaucoma. The early manifest glaucoma trial was the first adequately powered randomised trial with an untreated control arm to evaluate the effects of IOP reduction in patients with glaucoma. So the patients had glaucoma and they treated some and didn't treat others. So in this day and age, this study wouldn't pass the ethics committee. But it did show that treatment significantly delayed progression, and for every millimetre we dropped the pressure, there was a 10% risk reduction of progression. So it definitely pays to treat the patients and get their pressure down when they have established glaucoma as well. The normal tension glaucoma study wanted to look at whether that group that had normal pressures, did it make a difference if we lowered their pressures? Because the pressure component was only one part of the disease in those patients. So that reinforced that patients that with normal tension glaucoma, if they were treated and their pressure was aggressively lowered by about 30% using medical therapy, there was a threefold, or the patients that weren't treated had a 3% greater chance of progressing. So there was definitely benefits of lowering the pressure in the normal tension group as well. Now, what about the patients with advanced glaucoma? The advanced glaucoma intervention study looked at patients already on maximum treatment and randomised them either to laser or trabeculectomy, the surgical treatment. And it identified that if a patient had a pressure consistently under 18 in the post-operative period extending for the next 6 years, their chance of stabilising their visual function was much greater than if their pressure fluctuated over 18. So again, this study provides the basis for our argument to say to our patients with advanced disease, we need to operate and we need to get your pressure down under 18 consistently and keep it there. So what are the principles of managing our patients once we've identified glaucoma? What you want to do is you want to halt the progression and maintain their vision for the rest of their life. And the intraocular pressure is still the only modifiable risk factor that we have. Lowering the pressure reduces the risk of glaucoma progression, as I showed, at all disease stages. What we don't have are an ability to modify the non-pressure dependent factors, especially with that normal tension glaucoma group, because a third in that group
even if you lower the pressure, there's a third that will progress, and that's the frustrating group that you can't offer them at this stage. We haven't got anything else to offer them in terms of other treatments. We do know that in that normal tension glaucoma group, there are some factors like sleep apnea, nocturnal hypertension, vasospasm for migraine, or Raynaud's phenomenon that seem to occur more commonly in this group. So in our history taking, it is important that if we have a patient with normal tension glaucoma, if we identify something in their review of systems that suggests that one of these factors may be at play, then we usually recommend that they see their GP to have either 24 blood pressure monitoring, sleep apnea studies, and by treating those problems, then it often stabilises the optic nerve progression. So there is a role for maximising and maintaining overall health and well-being, because that improves the ocular perfusion, the perfusion of the optic nerve. So are there any effective pharmacological treatments other than lowering pressure? As I said, not yet. We're some way from neuroregeneration. There are a number of agents that are neuroprotective, and they've been validated in sort of in vitro, ex vitro studies, but none of the clinical trials have supported their use in clinical practice at this stage. So when we see a patient with glaucoma, we get the baseline pressure. We're aiming for about a 25 to 30% reduction from that starting point, and we usually call it the target pressure. What are we aiming for to start with? But with each visit, and we monitor the fields, we look at the optic nerve, we have to reassess what our target pressure is, because sometimes if a patient's progressing at what we have said is our target pressure, then we have to aim for a lower pressure. So we need to adjust depending on progression, and the pressure that's ideal for one patient may not be ideal for another. And often patients have spoken to their neighbour and the pressure's 18, and the pressure's too high for the neighbour, but they're wondering why you're happy to accept 18. So it's important that they understand that it's different for every individual. So when we start treatment, we start with first-line medications, a single agent, and because we're more likely to get adherence, and the more treatment you throw at the patient, the less chance that they're going to adhere to it. Selective laser trabeculoplasty is a treatment that can be used first line, but tends to be reserved for second line. A lot of patients are afraid if you say, "Oh, we can treat this with a laser, you don't need to use drops." There's a fear element, and even with adequate explanation. So it's often a good thing to get patients started on drops, and if they find that it's very difficult to use the drops, or compliance is an issue for younger patients because they've got busy lifestyles, they forget, then selective laser trabeculoplasty is an excellent treatment modality. And as I said earlier, at follow-up we check the pressure response, we monitor visual fields, the optic nerve appearance and the nerve fibre layer, and we adjust the target pressure. If we're at a maximally tolerated medical therapy, they're on everything, and we may need to consider laser or surgery at that time as well. So the patients, through this process, it's really important that the patients understand the role and the limitations of therapy. And there's so much information to take in when you're first giving a diagnosis of glaucoma. With every visit, it's reinforcing, providing support, and if you have patients that have a diagnosis of glaucoma, I think general practitioners have a very important role in supporting that patient as well, because they're dealing with a lot of other chronic diseases, and it's very similar in the approach that's required. So there are about 5 main classes of drugs, usually in drop form, and most of these achieve about a 20 to 35% reduction in pressure, about 5 to 7 millimetres of mercury. And as I said, it's important that patient adhere to the treatment, because if you use it haphazardly, you can get wide fluctuations of the intraocular pressure, and those wide fluctuations can be more damaging to the optic nerve. So, and the patients don't realise that their eyes are comfortable. They've missed the drop a couple of nights, they've gone away, they've got to take it with them, and all of those things impact on disease progression. The thing is, though, it's an asymptomatic disease. They feel well, and all the drops can have the potential to cause side effects, and that influences the patient's compliance. So the treatment aims to either works at reducing the amount of aqueous that's produced in the eye, or it facilitates the aqueous removal from the eye. So just back to, I don't know how much of the eye anatomy you remember, but the ciliary body, where are we? Here. The ciliary body produces the aqueous. It circulates through, drains through trabecular meshwork. That accounts for about 70% of the outflow, and there's about the alternative pathway sort of between the ciliary body and the scleral tissue. So the drugs work at either one area or the other in promoting the flow. So as I said, there's 5 classes. The prostaglandins you would have, and that's the generic list there. Beta blockers, the carbonic anhydrase inhibitors, alpha agonists, and the miotics. So as I said, this just shows where the different drugs take effect. I'd expect my registrars to know, but I don't expect you to memorise that slide. So when we initiate medical management, you want to use the agent that's going to get you the best pressure lowering, minimise the number of drops, and the fewer side effects. And so in terms of efficacy, you can see the slide shows prostaglandins, which are daily dosed, are probably our first line, beta blockers, second, alpha agonists, carbonic anhydrase inhibitors, third line, and miotics are reserved for certain forms of glaucoma. So here we've got the prostaglandin analogues. They all have a very similar effect on pressure reduction. It's most effective and convenient because it's once a day, and they've got the fewer systemic side effects as compared to beta blockers, and they're safe to use in the elderly. The local side effects can be significant, though. A lot of patients describe hyperemia or conjunctival injection. The eyes are red, they look like they've been smoking the wrong thing, and they've been on the grog all night, and so you have to listen to them, because most of the time the conjunctival injection settles after about 6 weeks, but if it continues and they're miserable, I usually switch to an alternative drop. Eyelash growth and the periocular pigmentation occur. The other thing is the iris pigmentation. All of that class of drugs increase the melanosome deposition in the eye and around the eye. So if patients have an issue with the potential for their eye to change colour, then you may need to look at an alternative. But when you discuss with a patient that it doesn't adversely affect the eye in terms of, and it's a physical thing, an appearance thing, then most of the patients are happy to continue. So not all of them develop colour changes, and although they're irreversible, they don't progress when you stop the drug. The more common change is the lash growth, and you can see in the slide here the patient's using a prostaglandin in their left eye, and you can see what we call the luscious lashes developing across there. Most patients don't complain about that. Now, the skin pigmentation, more common in patients with darker skin. That is particularly common and distressing to patients, and I usually recommend it occurs regardless, but a lot of patients have a lot of spillage when they put their drop in, and that excess drop on the skin results in the increased pigmentation. So I sometimes are in a position where you don't have other alternatives, so I encourage patients to use a Vaseline across the lower lid before they instill their drops, to put the drop in and then wipe away the excess, and it's surprising how quickly that goes away. So I suspect that a lot of drop gets poured onto the skin, and that leads to that situation. But there are ways that if you show the patient that you are listening and you have strategies for changing the problems that they're experiencing, you often get their better compliance. Beta blockers, again, are excellent in reducing the intraocular pressure, and the problem is obviously that both selective and non-selective beta blockers have a lot of other side effects, and it's important that we ask our patients, particularly our elderly patients, if they're developing any side effects from the beta blockers. Airways obstruction is obviously one that we all know, but even if patients don't have asthma, the elderly seem to be more sensitive to the beta blocker effect over a period of time. So if they've been on beta blockers for some time, it's important that if there's a cough that doesn't go away, some bronchospasm that's developed after a viral illness that's not clearing and they're on topical beta blockers, then it's important to make the ophthalmologist aware, because that could be a factor in their ongoing breathing difficulties. Depression, reduced exercise tolerance, impotence, heart block, bradycardia, a change in the lipid profile. They're all possible with beta blockers, and I find that if we don't ask the patient, they're not going to volunteer any of that information. So younger patients that are on beta blockers, it's surprising how many do come tell me, well, actually, yes, I used to run, I don't run anymore. Often they've come to me because they've been treated elsewhere for many years. So by asking certain questions, you can modify their treatment plan, and it improves their quality of life. There are ways we can still use the drug. There's gel formulation of a beta blocker, Niagel, which is 0.1%, and then you don't get as many side effects. The other thing is to use punctal occlusion. I encourage all patients to block the tear duct by doing punctal occlusion here in the corner of their eye for about 2 minutes after their installation of the drops. It reduces the amount of drug that goes into the nasolacrimal duct and is absorbed by the nasal mucosa, and so you're getting the effect where you want it and fewer systemic side effects. But Taxolol is one of the other beta blockers, less systemic side effects, but less effective in lowering the intraocular pressure, and has to be used twice daily. Carbonic anhydrase inhibitors, you'd all know Diamox. Well, there's a topical version, and it's all of these drops over the last 15 years have revolutionised glaucoma management. It decreases the production of fluid in the eye. They produce 14 to 17% pressure reduction, so not as good as the other agents, and that's why they're used as second and third line agents. It's not as effective as the oral acetazolamide, but the number of side effects in patients from oral acetazolamide, you wouldn't be using it unless you had patients with pressures over 50 that you needed to bring down fairly urgently. So the Diamox, as you're all aware, has a lot of systemic side effects and drug interactions, so we only reserve it for certain situations. And patients need monitoring of their electrolytes and their blood counts. Just from the topical drops, they produce a bitter taste. There's a bit of blurring of vision. The corneal decompensation can occur in predisposed corneas, but that's not very common. And because it is a sulfonamide, Stevens-Johnson syndrome has been described. I've never seen it related to carbonic anhydrase inhibitors, but we need to be aware as clinicians when we're prescribing these things. And in the populations where there's a sickle cell disease, you need to avoid the carbonic anhydrase inhibitors. So again, the systemic carbonic anhydrase inhibitors we don't use, or you need to use a reduced dose in patients that have got renal failure, the risk of metabolic acidosis and the electrolyte imbalances. Alpha agonists are another class. They're clonidine derivatives. They have a very good pressure lowering effect, again second and third line agents because of their side effects. They have developed a Brimonidine with a purite preservative, which has shown a less potential for side effects. So I like to put patients on that so that it allows you to use the drug for longer. There is a tachyphylaxis, and the allergy is the main limitations of use of this drug. About 30% of patients develop an allergy to this drug, and I'll just show you some pictures shortly. But the other important thing is that it does cross the blood-brain barrier, so it's absolutely contraindicated in children, as it can cause induced coma. Here's a lady who had the itchy eyes. She started to get some scaliness around the eyelids, and you can see the fairly classic. I mean, I'm not sure that you can. It's not as clear on the slide, but patients with Brimonidine sensitivity classically get a follicular conjunctivitis, redness, and they get a teardrop eczematous sort of erythema where the drop runs onto their skin. And if patients come to you with that, then definitely it would be related to the Brimonidine. Sometimes the patients put up with symptoms for weeks and months, and patients have almost gone to surgery for repair of ectropion of their eyelid, but it's all related to the glaucoma drop, and that is all reversible if they stop the medication. The cholinergic agents were a very old drop. They still have a role in, as a glaucoma specialist, they still have a role in our patients with narrow angle glaucoma because they constrict the pupil and draw the iris away from the angle. So, and people don't like to use them because to get the best effect from them, you need to dose 4 times a day. And this day and age, we're not going to get patients using their drops 4 times a day. But in certain situations, we can use it effectively, and you will see it's still prescribed. But it does cause side effects. When you first prescribe it, they get headaches until they become used to the constriction of the pupil. It does cause, it does induce cataract over time, and they can get synechia, so the iris can stick to the lens. In order to improve compliance, what's happening is a lot of the drugs are being combined. So by combining one of the prostaglandins with the beta blockers, you get single dosing still, but you've got 2 drugs. You get compliance. You reduce the amount of benzalkonium, the preservative that's in the glaucoma drop. So patients, you reduce the amount of side effects from dryness from their glaucoma medication. And obviously you're prescribing these because the patient's not controlled on a single agent. Until this talk was made, there weren't, all of the combinations had timolol in them. There's a new combination with a carbonic anhydrase inhibitor and the alpha agonist and Simbrinza, and that's being rolled out over the next couple of months. So again, those patients may need a 2nd and 3rd line treatments, and you can't use beta blockers. So what are the non-medical treatment options? The selective laser trabeculoplasty, which I mentioned earlier, is a very effective treatment. It's lasering of the trabecular meshwork, so it basically works at the cellular level, stimulating the cells to pump the fluid out of the eye. And it's repeatable, so if you treat a patient and they get a great response and sometimes it lasts for 2 to 3 years, you can repeat it again at a later date if the effect wears off. Laser iridotomy, the slide shows the laser penetrating the iris. That is the treatment of angle closure, acute angle closure crisis. And you can see the picture below which shows the hole in the iris. The other picture shows a diode laser. The diode laser involves the application of laser to the ciliary body. It tends to be reserved for end-stage glaucoma where the patient's got a blind eye, high pressure, so all you're doing is trying to drop the pressure and get that eye comfortable. Then we have surgery. The surgery, the gold standard of eye surgery for glaucoma is a trabeculectomy, and essentially you're creating a tunnel within the scleral pocket and opening up through the trabecular meshwork so that the fluid can percolate out of the eye, and the conjunctiva is stitched over that flap that you've created. We use antimetabolites, mitomycin C, 5-fluorouracil, at the time of surgery now, because that increases the success. By applying it locally, it increases the success of the surgery at 5 years. So obviously there's side effects if it's used by inexperienced people, but in our armamentarium as a glaucoma specialist, that's made a big difference to the success of these operations, and also our ability to achieve pressures around 8, 10, 12 with the operation. There are other options, surgical options, deep sclerectomy, cataract surgery in eyes with narrow angles and pressure does help to lower the pressure. So in patients with angle closure, and particularly elderly patients with significant cataract, often that's a treatment that can bring the pressure down as well. And there's drainage tubes which put into the anterior chamber or into the back chamber of the eye in situations where trabeculectomy has failed or in certain other forms of glaucoma. So, as I said, to achieve the goals of treating glaucoma, we need to have good compliance. And there's good evidence that up to 50% of patients don't use their medication as they've been prescribed, and it probably accounts for about 10% of progression of glaucoma. So it's important that we are aware of it. And you know, the patients are elderly, they've got arthritis, they've got a tremor. We're asking them to bring a drop over their eye and get it in the eye without pouring the whole bottle. And although the bottles have enough volume to last a month, the number of patients that tell me that the pharmaceutical companies have ripped them off because there's only 2 weeks' worth or 1 week's worth, and you hate to imagine how much gets poured down their face. Access to appointments is also one of the factors that results in progression of the disease, because patients may not be able to get to the appointment. They're elderly again, they've got unstable family situations, they don't understand the disease. The number of patients you call up and say, you've missed your appointment, but my eyes are fine, I don't need to see you again. I've got the GP's writing out the prescription. And it's really important for them to understand that it's not just a matter of using their drops, but monitoring for progression. And this is reinforced at every visit. It's important to keep talking to the patient so they understand why they're coming and why you're treating it. And poor understanding of our instructions. Sometimes you might be in a rush and you may not say everything you need to say, so it's really important that you reinforce if they're having trouble with installation of drops, to guide them and also to direct them to resources. The other thing is, it's a chronic disease, it's asymptomatic, and just like every other chronic disease that's asymptomatic, if they don't understand why they need to be using their drops, you're not going to get their involvement. The cost. Younger patients who may be on 2 or 3 drops will tell you that it becomes a significant, some of the newer drops up to $30, and if they've got bad disease, and I've got a lot of patients in their 30s and 40s, that cost becomes an issue. So this is where selective laser trabeculoplasty, if it works for them, can be a way in which you can reduce the financial burden on patients. The side effects of medication, and again, multiple drug therapy, if they've got a lot of treatment that they need to be on, that could be a factor in whether they're using their treatment or not. As I said earlier, it's important that we maintain good communication with these patients so that they understand why they're doing what they are doing, and so that the importance of as a doctor to be able to listen to these patients, because if they're complaining of itchy, burny eyes, there's a good chance that they're not going to be using their treatment every time you put the drop in. So if you listen and give them options, give them alternatives that they may be happier with. There are aids that are available through Glaucoma Australia that patients can put the dropper in, and help to steady their hand and deliver it much more accurately. So if you have any patients that express concern about their ability to get their drops in, Glaucoma Australia is an excellent resource. And a lot of the eye drop companies have put out resources to help patients, their starter packs that they'll have a magnet or a little reminder, so that it will help patients get into the rhythm of using their treatment as instructed. So as I said, the challenges in effective glaucoma therapy is that it's an asymptomatic disease, it's still poorly understood, and we know that prescription filling data shows perseverance is poor. So adherence and perseverance are a significant barrier to successful treatment. So as general practitioners and healthcare practitioners, you have to see glaucoma medication within the context of the patient's overall list of chronic disease medication, be alert of the interactions, the local and systemic interactions and side effects that can occur, breathing problems, falls, blood pressure, because patients are often going to see you first if they've got a red eye, and help patients to understand the purpose and effects or the side effects of their medication. So the patient's the centre, and we're all sort of linked, and we have an important role to work together to get the best outcomes of patients with glaucoma. So the
GP is a critical link in the chain of glaucoma management. Help them with their medication, prescribing medication if they've run out. A lot of the times I will post scripts. I tell the patients that not running out of a script is no excuse for stopping their treatment, because I'm happy to post them a prescription to keep their medication going, and even faxing it to their chemist, because I am, the number of times that they will have stopped, and sometimes it won't go up high, but then you've got the patients where it escalates back to 40, and there's damage, irreversible damage that we can avoid. It's important that as GPs you use the patient and health professional resources available, and don't hesitate to contact Glaucoma Australia, or recommend your patients to Glaucoma Australia for support. So Glaucoma Australia runs a media campaign improving patient awareness through World Glaucoma Week. It's got pamphlets and support groups, community meetings that it runs. It supports research, and there's project funding, and of course supports patients and help. I mean, a lot of patients that may be diagnosed with fairly advanced disease in their 50s and 60s, it's quite a shock, and so Glaucoma Australia, I know, provides a lot of resources to those patients and guides them as to, and obviously the more savvy patients will use the internet, but they can be guided as well. I have a website that I've put some resources into, so patients from the different procedures, to also directing them to reputable sites, both through the College of Ophthalmology and the American Academy of Ophthalmology. They've got some fantastic resources for patients who want to find out more about their disease. Now lastly, as I said yesterday, I think this is too negative. Effective treatments are available, but there's significant limitations. The disease is still incompletely understood. There's side effects for medication, there's treatment morbidity, and there's adherence barriers, but that's too negative. So I think the important thing is that if we recognise the disease early, we can make a big difference to these patients. And I say to them, my role, if we work as a partnership, is to get them to the grave with great vision, but it takes everyone in that chain link to make that possible, including the patient. Thank you.